but that's okay. And I've got to put.
Okay,
so my name is. Oh, go ahead.
No, if you want to introduce yourself, you're more than welcome to.
Yeah, I'll do it. I've got a little introduction slide coming up. So my name is John Hundley. I'm the surgical director for liver transplant at Piedmont Hospital here in Atlanta. One of 2 adult liver transplant centers in the state. I would love, since it's a small group, if you all know how to chat, you can put in there if you're pre-transplant, post-transplant, if you're willing to do that, just so I kind of know who we are, since it's a smaller group. I'll try and tailor what I'm saying to the group a little bit. So that's a picture of our new hospital there. So I'm just throwing this slide up to let you see all the places I've been over the years, in case there's a personal connection there. I've been at Piedmont Transplant for 9 years, coming up on 9 years in February. I do liver and kidney transplant. I was the liver director at the University of Kentucky before I came to Piedmont. And then I came to Piedmont, was a kidney director for a while, and I'm now the liver transplant director. Wow, Karen, 20 years ago today, liver transplant. That is amazing. Congratulations. So we're gonna keep moving. This is my family. A couple of Halloweens ago, we were all Harry Potter people. I can't even remember the name of the big giant that I was, but anyway. So we're gonna just talk. I wanted to do a talk that would be good for both pre and post-transplant patients. And the first one is just kind of understanding the risks of cirrhosis versus liver transplantation. We're going to talk about the current liver allocation policy, effects of the COVID pandemic on liver transplantation, and the next thing is life after transplant. And then the last section is, and with us having such a small group, we'll just take everybody off mute at the end, and you can ask me anything about anything you want, including Kentucky basketball, Chelsea soccer, anything like that. All right. So we're going to start with just understanding cirrhosis and the risk. And a lot of you all are living this, but the liver is a really important organ. Obviously, it's the factory that keeps the rest of your body happy. It does a lot of different things metabolically, and when things don't go well, a lot of times the thing that makes the liver not, using my cursor here, I hope you can see it. Let me know if you can't. But the portal vein is really the culprit in a lot of complications. Oh, Mr. Snow, hello. It's good to see you. I can't wait to hear your voice a little later. So the portal vein, when the pressure gets high in the portal vein because blood can't get into the liver anymore, that causes a lot of the problems that we're going to be talking about over the next couple of slides. So basically, your liver, cirrhosis means hardening of the liver. And when your liver gets hard, it's because of scar tissue that builds up because of repetitive damage from whatever, hepatitis C, alcohol, hepatitis B, all kinds of different things. And that scarring leads to blood not being able to get into the liver. So the liver factory part, so the parts of the liver that do all the work, are damaged, and that impacts you. But also, blood just can't get in. And the portal vein drains blood from your bowels into the liver. And when it can't drain, you get a lot of problems. So one of them, and this is just a patient that we transplanted several years ago, you start losing muscle mass. So you need, when you develop especially a lot of ascites, a lot of fluid in your abdomen, and you have to continually have that drained, you're losing tons of protein. And just in liver, cirrhosis leads to a lot of loss of muscle mass. And this is just an example of that. You can see the clavicles, the facial bones are all very prominent. And that's not because they've grown, it's because the muscles surrounding them have shrunk away to nothing. So this big belly here is a picture of somebody with a massive ascites, which is where fluid accumulates in the abdomen because blood can't get into the liver anymore. And so the bowels get swollen and fluid just starts kind of leaking into the abdomen. You can have you can develop fluid in your legs, so a lot of swelling in the legs. This is a chest X-ray that shows fluid in the lungs. This is a CT or images of varices. So when blood can't get into the liver, it has to make its way to the heart somehow, and it typically chooses to follow the esophagus up into the chest, and those veins under the surface of the mucosal lining, the lining of the esophagus, are called varices, and those varices are taking blood back to the heart. If you get a little bit of acid onto those and you have a rupture, that's what leads to variceal bleeding, which can lead to a lot of problems. This picture of the abdominal wall up here is just somebody that had a lot of varices between their skin and their muscle. So all these veins got really swollen, and that's a way that the blood got back. So people can have varices, these big swollen veins, kind of anywhere. What makes a liver transplant so complicated and risky as an operation is that you have varices all around your liver, and that they are very prone to bleeding, which can make the liver transplant really complicated. Question mark is just to remind me of talking about hepaticencephalopathy. So that's a fancy word for saying that you get really confused with liver failure. And we have medications to treat that, but a lot of patients have really poor quality of life because they're constantly kind of a wave of really bad encephalopathy, and then you treat yourself and it gets better, and then it gets worse and better, and in and out of the hospital because of that. This is a little cartoon of a kidney. Excuse me. Kidney failure is very common in patients with cirrhosis, and so this is just one example or a cartoon of a kidney, but that's very common, especially in the later stages of cirrhosis, for you to start having kidney disease. Cancer. So this is a picture of a cancer that's developing in the liver. Hepatocellular cancer is very common in patients with cirrhosis. That's why all cirrhotics should continuously get screened for cancer to treat it, diagnose it, and treat it early. Liver cancer, when it's in its kind of medium stages, is a big indication for liver transplantation. Patients with liver cancer that get transplanted do very well compared to every other modality of treatment. So this is kind of what life is like before transplant. And some of you may have seen this slide. I hope you haven't seen this talk already, but you're kind of like running along, doing fine, and then you crash, you go to the hospital, you crash, you make it home, something else happens, you have a bleed, you have an infection, you have bad confusion and encephalopathy, and you're back in the hospital. I also just like this slide, so it's kind of funny. If you watch your feet, it's kind of funny how they kick up in the air. But so the question always arises, the obvious question of when do you actually need a liver transplant? And it's pretty simple from a kind of logical standpoint. It's when the risk of death without transplant is greater than the risk of death with transplant. And to know the answer to that, you have to understand, what are the risks of liver transplantation? Across all patients, 1% of patients in this country die during a liver transplant. 4% never go home, so they die in the hospital. Those numbers might not seem huge to you, but if you're that 1% or one of the 4% that never make it home, obviously that's a huge number. Infections are common, drug side effects, recurrence of liver disease can happen with cancer, HCC, or hepatitis C, primary sclerosing cholangitis. Those things can recur. Long-term, you're on immunosuppression, and so you have an increased cancer risk forever. The risk isn't huge. So like if, let's take colon cancer. If your risk before being on immunosuppression was 1%, then it would go up to 2%. If your risk was 0.3%, it would go up to 0.3 or up to 0.6%. So it's not like it's a gigantic increased risk, other than for people that are fair-skinned, especially non-melanoma skin cancer is really common, and kidney cancer is a lot more common as well. But when you look at all patients after transplant, about 9% of them die within a year of transplant, and the median survival is right around 12 years. So that means that at 12 years, half of patients are still alive with a liver transplant. So that's the risk of the surgery. Now let's talk about the risk of not having the surgery. What's the risk of dying without a liver transplant? And it really depends a lot on your MELD score. And I just want to welcome you before we unmute you at the end. If you want to be, have a question anywhere along, I'm trying to keep my eye on the chat box, and if you can type it in, I'm happy to stop and talk for a sec. So the MELD score incorporates 4 lab values that give us a score, and this score is purely to predict your risk of death with and without transplant. So it goes from 6 to 40. If your MELD score is 6, that means that you have a 97% 1-year survival without a transplant. So you only have about a 3% chance of dying without a transplant in the next year. On the other hand, if your MELD score is 40, you have less than 1% chance, it's really 0, of surviving a year without a transplant. And you see all these other numbers in between. So the question is, where do you see the benefit? And so to know that, we have to know what's the 1-year survival with a liver transplant, and it's about 91–92% overall. If you look at a MELD score 15, that's the first kind of number where there's a clear-cut advantage with transplantation. 92% 1-year survival with a transplant, 86% without. And then once you make it to that 1 year, your survival starts to really mirror other people that are your age with your medical conditions that are on immunosuppression. And so once you get through the first year, you can live forever, for a very, very long time, without problems. And, I think we have a person like that on the call right now. Our MELD in Georgia, the median MELD that we transplant at is 29. So you can see most people with a MELD score of 29 would have, a 5% chance of surviving a year without transplant. Their 1-year survival would be around 88–89%. And so that's kind of the standard person that comes through. So hopefully that helps you understand kind of who would need a transplant. Another way of thinking about this is that if your MELD is 6, you're almost assured to live a year. MELD of 28, your median survival without a transplant is about 3 months. MELD of 40, it's about 12 days. And with the liver transplant, it's about 12 years. So, there are a lot of things that are important to do while you're waiting, which is try and take care of yourself as well as you can. One of the things that I really want to stress is just exercise as much as you can. If all you can do is walk to the bathroom and back every day, then do that as many times as you can. Anything you can do to keep yourself strong and eligible for transplantation. If you get so weak that you can't walk, it makes it very hard to recover from transplant. So that's one thing I would just stress to those of you that are waiting on the list. So what are some marginal donor livers? Marginal just means that we think they're acceptable to transplant into some people, but not everybody, and certainly wouldn't use them for the people that are in the ICU very sick with a MELD of 35 or 40. But there are a lot of people that are waiting on the list. I'm actually transplanting somebody in a few hours with a DCD donor. So one of my partners is about to hop on a plane and go do one of these. And so a donation after cardiac death means that the donor, instead of being brain dead, and when they're brain dead, the heart's still beating, everything's going, and we get everything ready, and then we flush the organs, and the organs are happy right up until the very end. With DCD donors, those livers are not happy for a time, because we take a person who's alive to the operating room, and then the ICU team withdraws care in the normal way. And if they die quickly, then very quickly we do the operation, remove the organs. But for that period of time between withdrawal of care and death, the liver is just not happy. It's not getting great oxygenated blood. And so that has a higher risk of having some ischemic problems or lack of oxygen problems to the liver that can lead to some bile duct issues. So that's an example of, we wouldn't give that to somebody who's right at the top of the list. Today I'm giving one to a patient with a MELD of 16 who's just miserable. No hope of a transplant from like a normal, perfect, brain dead 25-year-old donor, but just miserable and needs the transplant. And so that's the kind of patient we use for DCD livers. Fatty livers do well in patients with good hearts that can kind of tolerate the operation of having a fatty liver. When you perfuse blood through the new liver. It gets to the heart can stop. That's a bad thing, obviously. Older livers do great as long as they have good blood supply. Their artery isn't calcified and everything else looks good, but we're somewhat selective with who's appropriate for that. And then infected donors, hepatitis C, hepatitis B, COVID positive donors. Those are all patients that have risk factors that we talk very seriously with our recipients to make sure that they understand the risks. But even COVID positive patients that are no longer considered infectious, we use those livers. Soon, I think we'll be using them regardless of whether they are fresh COVID or not, because abdominal transmission of COVID is thought to be very, very, very unlikely and hasn't happened yet. So this is the incision that we make typically for a liver transplant. Take the whole liver out, put the whole new liver in, hook everything back together again, and pray that it all goes well. If it doesn't, you can have where the artery or portal vein are hooked together, they can clot off, and that can be a devastating complication. The bile duct can leak, which can cause infections and cause a lot of problems. So that's something that those are things that are common that we deal with after transplant. This is a new transplanted liver that looks like it's working really well already. This is one of my patients that lets me share this picture without covering her face or anything. She actually wrote a book. This was the first liver transplant I did at Piedmont, and she had polycystic liver and kidney disease, and I actually took her liver out, which is most of what that belly was, and her kidney, and then did a liver and a kidney transplant on her. And you can see that she's just emaciated, lost all the muscle mass in her hands, her face, and everything. And this picture was 12 months later of what she looked like 12 months later. And I show that a lot to patients that are that have that degree of muscle loss, and just it's hard for them to imagine ever being normal again. And this lady has lived a great normal life since transplant 9 years ago. So current liver allocation policy, it's changed a lot over time. So I see a lot of you are post-transplant. I won't spend a ton of time on this, but basically we used to just share most livers within the state. And then if you were really, really sick outside of the state, you would get a liver transplant. That has changed dramatically for various reasons. And so now there are circles around the donor hospital for distance. So basically it starts with, if somebody's really, really sick, in a small circle around the donor hospital, they get it. If not, they go to a bigger circle and then a bigger circle. And then the next level of MELD score, the patients go to a small circle, and it keeps going like that. So that's how livers are allocated now. I'm going to skip this slide. And I'm happy to answer any questions about that, since I think there are just a couple pre-transplant patients on the call. I'm going to skip that, but happy to talk about it in our question and answer period. So the COVID pandemic, everyone assumed when it hit, and we certainly did, that transplantation was going to fall to nothing. So the first few weeks after the COVID pandemic hit in New York, transplant centers across the country just kind of shut down because it was a total unknown. We actually stayed open with high MELD patients. We transplanted several during the initial parts of the COVID pandemic because they were going to die without it, and we didn't know the risk, so we figured we should do it. Thankfully, those went well. But what's interesting about the COVID pandemic, and if you just look, and Angel, I don't know, can you see my chat box when I'm moving around or not? Because I keep moving it so you all can see the screen, but just let me know if it's in the way.
I have it, well, I see it popping up.
Okay, but on my screen that I'm sharing, like I'm moving it around right now. I don't know if you guys can see it.
No, we can't.
I don't want you to be able to see it. Okay,
No.
perfect. So these are the transplant volumes for all organs at Piedmont over the last 15 years. And as you can see, 2020 and 2021 have been actually huge for transplantation, not just at Piedmont, but across the country. And the reason for that is sad. It's really because of deaths of despair. So we have had so many more suicides and drug overdoses in the past year and a half because of COVID and all the anxiety and stress, and people just kind of realizing that they're alone during the time that we were, that everyone was staying home, that there's just been a lot more alcohol use, drug use, suicides, and that has led to an increased number of transplants. And we haven't really had to shut, COVID transmission is super rare with abdominal organs, and so we haven't had to slow the numbers down. So we've actually set records for transplantation across the country in the past 18 months or so. One of the reasons that we have a little bit of an advantage, we have an organ recovery center in Georgia now. It's now in our hospital at Piedmont, in the basement, and brain dead donors come to our hospital and have organs procured there. And we, Emory and Piedmont, both have this advantage, but it probably is a little more for Piedmont. When donor centers kind of back out of a liver at the last second, or recipient centers, we're able to be here and we're able to take those livers last second. It doesn't happen very often, but that's helped increase our numbers a little bit just here at Piedmont. And also Emory's been able to do that as well. So one thing I want to touch on the impact of COVID is that, across our transplant centers in the state, we are now requiring mandatory vaccinations for our patients on the waiting list. The reason is pretty simple. The number one cause of death in the last 18 months for all of our post-transplant patients is COVID. If you get COVID and you're immunosuppressed, you're at super high risk of dying if you haven't been vaccinated. It's much, much higher than the general population. And so we felt like it was not only better for our patients, but it's also just good stewardship of these precious organs. We had patients that we transplanted before the vaccines were available, and a couple after that transplant them. They do great, went home 3 months later, they got COVID and died. And that's, terrible for that patient, but it's also terrible for the person that died waiting on the list that could have gotten that liver. And so we have had vaccination as a mandatory thing, like most transplant centers do across the country. And I'm happy to talk about that at the end of this talk. So, which is getting close, by the way. I intentionally left a lot of time for question and answers at the end, because I think hopefully that's really what will benefit everyone the most, is just to have a chance to ask me kind of anything. So life after transplant. So for the vast majority of our patients, life after transplantation is great, and I hope we can hear if that's true for the patients that have chimed in and said that they're post-transplant. The patients that get through that first year of survival, most of them have a great quality of life. There's a gradually decreasing expectation for clinic visits and laboratory frequency or laboratory checks. Over time, it's every 1 to 2 months, depending on your initial diagnosis, and see us in clinic once a year. We're probably going to shift soon to, once you're 7 years out, you really don't need to keep making the drive back to Atlanta. Things are usually on cruise control. And as long as your labs are steady, you don't really need to see us. And so that's something that we are implementing this year at Piedmont, that after 7 years, if you have good primary care or GI help locally that can follow your labs and follow your progress levels and things like that, we will discharge you to them, which is good for people, especially that live far away. How long can you live? How can you live longer with a better quality of life? People ask that all the time, like, what can I do to just maximize? And it really is the same thing that all of us can do, which just the standard heart healthy diet, exercise, and managing your other medical conditions. Most patients that get a liver transplant, when they die from something else, not related to their liver disease or their immunosuppression or anything else. So most people die from the standard things that we die from in this country, heart attacks, strokes, things like that. And so that's, the best advice is just healthy diet, lots of good exercise, and good medical management for your other conditions. And then, of course, getting your labs checked and showing up for clinic is super important. Rejection isn't as terrible of a thing in liver transplant as it is in the other organs. The liver is not as susceptible to it, but it still happens. When we lose patients because of liver rejection, it is typically because they didn't check their labs for a while, and nobody knew that their enzymes were getting worse and that they were slowly rejecting the liver until it was too late, or they just stopped taking their meds. And, that's a surefire way to die, is to stop taking your medications, because you have to keep suppressing that immune, or the liver rejects and it can't recover. So, the last thing we've got, we started late. I intentionally made this a 30-minute talk because I wanted to leave as much time as you all need. So, Angel, if you can unmute everyone, and you all can just feel free to ask me anything. In a minute, I'm going to be driving soon to a soccer game for my son, and then I'm at 3 o'clock, Lord willing, I will be doing a liver transplant. I'm going to be coming off screen here, and I'm going to keep talking on the phone as I drive my kiddo to his game. I'm going to leave in about 10 minutes. But in the meantime, let's talk. If anybody has any questions, if not, we get an early departure from the meeting. But I hope that there'll be some people with some questions. And I'm going to stop sharing my thing so we can all see each other.
Hey, doctor, this is Chris Webb.
Does anybody?
Hey, I was going to ask you about liver transplants or the COVID positive liver transplants. You mentioned that in your slide, and it's something that I haven't really heard about. I haven't asked any of my doctors. And by the way, I was speaking earlier at the Faces of Hope. I was transplanted at Piedmont, Atlanta, a year and 9 months ago.
Nice. Congratulations. I hope you're doing well. It's good to hear your voice.
Thank you.
So yeah, COVID, it's slowly emerging data as people get braver and braver trying to use COVID positive organs, because, so many, 20% of patients on the liver list die waiting. And so it's something that has been slow, but where we are today is that if you are dying from COVID, in other words, you were admitted because of COVID, and you're within 14 days of that initial infection, that is something that is still considered kind of high risk. But if your COVID positive level, there's something called a cycle threshold of how positive is it, and if it's positive but it's a low level, it's considered not very likely to be infectious. And so we've been using those organs from abdominal organs for a while. I really believe that time will tell over the next few months that even if you die of COVID and you have active COVID viruses all over the place, transmission with liver or kidney transplant, abdominal organs, to people that have been vaccinated is almost certainly very safe. It's, COVID doesn't live in your kidneys or in your liver like it does in your lungs, obviously, and sometimes in your GI tract. So it's something that my gut feeling is that within the next 3 to 6 months, we'll have our national organization will just say, look, we really feel like if the recipient's vaccinated, it's kind of safe to do no matter what for abdominal organs. Lungs are a different issue, but probably heart and abdominal organs will be safe. So we do that now cautiously with people that are actively positive with COVID, as long as their cycle thresholds are high, which means that the risk of transmission is really low. You can imagine, with 20% of our patients dying on the waiting list, it's certainly in their best interest if we can use these. And, we always tell the patient, look, patient had COVID. And I transplanted last week a gentleman who was sick as can be, low MELD though, could not have a hope of getting a transplant from a quote normal donor. And the donor that he got was COVID positive, Hep C positive, Hep B positive, beautiful liver from a young person, and he was very happy to take it and has done really well with it. So, all right. Any other questions or any comments about that, Chris?
One other question in regards to that. So I did contract COVID less than a year after my transplant. I was lucky enough that it didn't affect me very much. I've had colds that were worse. But with that, what has been your experiences or our experiences as a team and as patients who have contracted and haven't done well after transplant? Has the number been large, or is there? Yeah,
it has been. So it's about you're about 15 times more likely to die from COVID if you get it, if you've been transplanted. So it's huge. It's a huge number. And that's why, ever since the vaccines came out and initial data on safety looked good, we've all been vaccinated, all the docs, and we've asked all of our pre-patients to get vaccinated, which is the best way to do it because they're not immunosuppressed yet, so they can almost always mount a good response to COVID. Our post patients, we certainly have encouraged them, whether they've had COVID or not, to get vaccinated. It's a little trickier, frankly, because they don't have the same response to a vaccine. You guys don't, that a normal patient would. So it's something that you can test for antibodies after you've been vaccinated to see, did it work? And if not, you can try a booster or try a different vaccine. That's something that, for those of you that are after transplant, if you haven't been vaccinated, I would strongly, strongly recommend that you do that. And, just across our national organization, you can imagine the political spectrum of our physician group is enormous. Right wing, left wing, middle, moderate, whatever. And every single person within all of the docs and transplant are perplexed by how is it possible that this has somehow become a political polarizing thing. Like, it is undeniable that vaccination keeps you from dying from COVID or greatly decreases the risk. And it really frustrates us when we have patients that have died because they didn't want to be vaccinated, heard from all their sources that it wasn't needed, and died from COVID. And it's tragic. With transplant, it's always tragic on two ends. It's tragic that our patient that we care about died, but it's tragic that somebody else didn't get to live because, they got an organ and then eventually died because of COVID. So anyway, this is a small group. I'm not gonna go person by person and say, have you been vaccinated yet?
Yeah.
But I really hope that you have.
Yeah, I did when it was available. Obviously, I caught it before the vaccine was available to me. So I was just lucky enough not to become very ill. But thanks for the explanation.
Sure. Hey, Karen.
I was just following up on the question that was just asked about COVID. I have been concerned. I mean, I would love to return to a normal life, but mine is better than it was last year. So I'm good with that. And of course, I've got 20 years post-transplant, so I got nothing to complain about. However, I would like to go out and do all these things that everybody else does. So I read, I'm sure you're aware of the study that was done by Johns Hopkins about 6 months ago this spring. And so I went in there and sliced and diced it and looked to see all the things that, relate to me. And what I came up with was I take mycophenolate mofetil, which I'm assuming some people on this call do as well.
Mm-hmm.
And I kind of figured out if I could get that reduced, then maybe I would be in a better place, because I saw that as, you know, the study I'm talking about, right?
Yeah. Uh-huh.
Okay. So I talked to my doctor and he said that, okay, that's fair. There's certain things he wouldn't do. So I had it reduced so I could be in a position to be in a readiness mode by the time I got my, my third, and I hope it helped. I have no clue. So what are your thoughts about what we can do to improve our chances with COVID?
Yeah, so I think that there's some things that we can just have broad strokes, like this is what you should do, this is what you shouldn't. The question that you're asking is really specific patient to patient. And the reason for that is that different patients have different degrees of immunosuppression requirement. In other words, if you have autoimmune hepatitis or primary sclerosing cholangitis as your baseline disease, you need a lot more immune suppression than the typical patient. And so there are some patients that it makes sense to lower their CellCept, their mycophenolate dose, to allow for the vaccine to have a better chance of kind of taking and for you developing an immune response, and also just to decrease your risk of dying from COVID in the first place. But for other patients, if we lower that level, they're going to reject the liver and die. And so it's not a perfect cookie cutter answer. I think the best thing to do for each of you is to just talk to your transplant doc And whether that's just through the coordinator and they talk to the doc and they look at it and decide, or it's, on a clinic visit. But, we've all been learning a lot about COVID, and it's all new for us too. The last 18 months, we don't know all the answers, but that study from Hopkins helped. One of the questions that we all have is, well, for how long? Like, how we are all wondering, how long is this pandemic going to be an issue? How long is it going to be, something that we have to deal with? And long term, if we knew that it was just going to be just like this forever, we would probably start tailoring our immunosuppression plans for everyone forever. But for now, we're just doing it person by person, as we kind of look at their risk profile for COVID and the risk profile for rejection. So I'm going to stay on the phone. I have to start driving my boy, but I'm going to stay on the phone so you all won't see me anymore. But I'm still here. So any other questions?
Yeah, I do. Hey, Dr. Hundley, how are you?
I'm good. Is this Mr. Snow? I can't see anymore.
Yeah, it is. Sorry.
Hey,
I
good,
appreciate
good to see you.
to help me, of course, but to change subjects quickly from COVID, the 7-year drop off. I've gotten a lot of pushback from my primary care and also from my gastroenterologist. They do not want to take responsibility for prescribing immunosuppressants primarily and doing labs, and they just don't want to take the handoff from. What can we do about that?
So it's a great question. If they don't feel comfortable, so it's not like a mandatory thing for us. Honestly, we planned it because there's so many patients that do come in that 7 to 10 year, 7 to 20 year in Karen's case range, where they're like driving 3 hours and they say to us, like, our GI doctor, my primary care doctor, was wondering, like, do I have to keep coming back? And so that was really what drove the change. It's not a mandatory thing. And if you don't have a physician that's comfortable with it, then we certainly don't want to force that. And so that's, and if you're hearing something different, this is a change for us at Piedmont. So if you've heard something different than that from your coordinator, that's, let me know.
Crystal Moore is my coordinator at Piedmont, and she just mentioned it. I'm coming up for my clinic, my 7-year in January, and I'll discuss it with them then and see.
It certainly isn't it's not like we're not kicking anybody out. We're basically giving you the opportunity to not have to see us anymore when you're doing so well. But if you don't have a physician that's willing or able or capable or feels uncomfortable and not confident, then we're certainly happy to keep following you for life. So don't worry about that.
Okay, thanks. I appreciate that. That's all I really had at this point.
Okay.
Hey, Mark, they tried to do that at Emory to me a few years ago. They said, you don't have to keep coming back. And I go, yeah, I want to. So,
yeah, exactly.
I mean,
please don't kick me out.
Yeah. That's exactly right. Like the reality is that once you're that stable, most patients on steady doses, as long as you're getting labs checked, and the way that we've done it with our providers is primary care doctors and GI doctors, whoever's going to be following, is just some general parameters like Prograf levels in this range. If they go outside of that range, you can call us and we'll help adjust it for you. It's mostly it's something that we want to do for the patient, not, it's certainly not a hassle at all to keep managing you. So happy to keep doing it.
We've all worked so hard to get to this point, 7 years or longer, and I feel comfortable going back there every year, and at a minimum, if I need to. But I've been very lucky, and You know, I'm on 1 milligram of sirolimus a day, and that's it. And
Yeah, that's great.
yeah,
Yeah, and we're for every one person like you and Karen, there's another like 2 or 3 people that are like, yeah, I'd love to not have to come back to Atlanta again.
Okay.
So it just depends where you live and what your situation is. So we're happy to keep you forever. So
all right, thanks.
sure. Any other questions?
Dr. Hundley, this is Chris Hoover. I don't really have a question except for, is there any early detection on cirrhosis of the liver? I moved to Atlanta, Georgia, right out of college, went to NC State University and moved to Atlanta. And when I first moved down here, I was given blood on a regular basis. And after about 4 years, they said my liver enzymes were elevated. And so I talked to my primary care doctors, and they didn't seem to be worried about it. And then about 3 years ago, my Dr. McClatchy, wanted to have a scan, and they figured out that I had an enlarged liver and spleen. And about 2 years ago, we were up in North Carolina. I'd gone up to visit family. We'd eaten all day, so I thought I'd eat healthy, and I got a salad. And we were driving back to our hotel, and I started throwing up blood. I lost a third of my blood supply. So I almost died from blood loss, which is kind of where I am. I see Dr. Shrestha. He's great. He does the endoscopy every month. But is there something I could have done beforehand? That's really what my question is. And of course, it's too late now.
Yeah,
but
no, that's a great question, and it really depends for each patient on what the cause of their liver failure is. And you can, if you want to tell us, you can. You don't have to. But the cause of your liver failure has a lot to do with, is there something you could have done to prevent it? The reality is that almost all patients are diagnosed late. And the reason is that there isn't a great screening tool for early, like liver enzymes that are a little high are extremely common for a million different reasons. And testing, like, doing liver biopsies to check for cirrhosis at that stage would result in more harm than good for if you did it on a kind of population level. There's a test called a FibroScan that is non-invasive, that is good for measuring levels of fibrosis in the liver. It's not readily available. Most hospitals don't have it. Certainly family care facilities don't have it. As far as I know, there are only 3 places that have it in the state, which are Piedmont, Emory, and then there's a hospital in Augusta that has it. So FibroScans can kind of show fibrosis early. The reality is, for most people with liver disease, is that there aren't things that you can do to keep it from happening. So for many different kinds. So like back in the day, before Hep C treatment came out, if you had hepatitis C, the treatment was very poor. There weren't good options for treatment, and patients really just kind of had to wait and see, how long they had before their liver started to fail. Now that's better with hepatitis C treatment. Obviously, if your primary disease is alcohol, if you can stop drinking before you develop cirrhosis, then you can save yourself. But if a lot of times, people drink, they stop drinking, they have cirrhosis, and that just slowly gets worse and worse, and it's kind of too late. So without knowing the details of your etiology of your disease, I can't tell you for sure if there's something you could have done to prevent it. But in many cases, there isn't anything. There's nothing that can diagnose it early. Unfortunately, like I said, liver enzymes being a little elevated, that's not even true for cirrhotics. Like most cirrhotics have normal liver enzymes. it's not until later in cirrhosis that your bilirubin starts to go up. But if you just, if we just check, every patient in the country that has cirrhosis, the majority of them, their liver function tests are actually normal. And so it's
Wow.
not there are no great screening tools for this. So my gut feeling is there probably wasn't anything that could have been done to capture it or to identify it ahead of time. But without knowing all the details, I can't say that for sure.
So what about hereditary? Mine's non-alcoholic, and I had an uncle that had similar. He was a little bit older when he was diagnosed with non-alcoholic cirrhosis of the liver. And so the only thing I can figure is I love cheese, and I've just eaten too much cheese in my life as part of it. And I am type 2 diabetic.
So NASH or non-alcoholic steatohepatitis or non-alcoholic fatty liver disease, those things, eating better and controlling your diabetes better, those are two things that can certainly predict or slow down your risk of progression of liver disease for sure. So when we see people that are young with early signs of fatty liver disease, if they lose weight and if they don't become diabetic, or if they're diabetic, if they control it well, that makes a huge difference. So, so it could have been possible back then. I'll tell you, at this point, with you're already there, you've got cirrhosis, you've got varices that are bleeding. There isn't anything you can do to reverse it at this point. So
yeah, I understand that.
Heart healthy, yeah. So I know we're a few minutes ahead of time or beyond our time. If you have any more questions, I'm happy. I'm driving on the highway now. I'm happy to answer anything you have. And if not, thank you for taking the time to meet with us.
Hey, I had one last question if you do have a minute.
Sure.
So we all talk about, and I think we all know that we need to continue taking our medication, and I'm sure we all do, right? And do it on time. One thing that I've always wondered, because I have missed a dose or two here or there, nothing's ever been like routinely missing anything, but I remember one time I missed a dose and freaked out and, called doctor. They said it's fine, just don't make a habit of it. So when does missing doses actually become really dangerous? I know, and it isn't a question I'm asking so that I can miss doses and feel safe. I just, it's something that I think all of us are curious about what the real timeline is there of when it becomes dangerous.
Yeah, no, it's a great question. So, the immune system is a finicky thing. It is possible to have normal levels of immunosuppressive drugs in your body and still reject your liver. And there's all kinds of things that happen that can stimulate. All it takes to reject your liver is one or two T cells in your body kind of waking up and getting revved up by something. A memory T cell might get revved up by some other infection. You get a cold, and then this cell identifies, hey, what's this liver doing here? You're not supposed to be here. And that's all it takes to start, doing it. So it's a little bit of a difficult question to answer, because it's, the way that we know that you miss too many is that you start to reject. In general, if, like, for instance, if you're on this kind of standard Prograf CellCept regimen early on, if you just either forgot or didn't, or decided not to take one of those for several doses, 3 doses, 4 doses, we would expect to see a rejection kicking in at that point. So it's usually within a couple of days of taking off immunosuppression. It's not, and I appreciate that you're saying, well, I'm not asking permission to just skip them, but if you miss a dose here or there, it's unlikely that you're going to reject. But if it just happens to have been coming on at the time that you were prone to rejecting anyway because of something else going on in your immune system, then if you miss your dose on the wrong day, like, it might be the thing that kind of starts the rejection occurring. And once rejection starts, it's hard to slow down without added medications and treatment. And so that's why, you know, the laboratory checks are so important, to catch it in time to save, you know, to turn things around. So I don't know if that answered your question. There isn't a perfect answer to it. We always stress, like, don't miss any doses, but in terms of like when, like if you wound up like on a trip and realize, oh my, I don't have enough medication. If it's more than a day and a half, 2 days, that's when I would start getting worried and wanting you to check labs to see, you know, are you actively rejecting yet?
Gotcha. Yeah, that's great. That's exactly what I was looking for. And the final piece to that is, let's say we, for whatever reason, we forgot our morning dose, right? Busy, whatever, and say 4 hours later, you realize you missed that dose. What's recommended to do at that time? Take it or wait till the next dose?
I'd take it then.
Okay.
So if it's 4 hours and you've got 8 hours left, I would take it. If you're, you know, at 10 hours and you usually take it at 7 o'clock at night and it's 5 o'clock and you're like, oh, I didn't take it this morning. I would take it. I would take a dose then and then wait till the morning to take the next dose. So I wouldn't double up at that point. If you double up, especially on Prograf or cyclosporin, if you take a double dose, peak that you can get can start to hurt your kidneys or something else. So it's not something that you want to double up on. But like the way you described it, I've got 8 hours to my next dose. Yeah, I would just take it then and then take it again 8 hours later, or maybe space, you know, do 10 hours later and then go back the next day to your normal thing. But yeah, it's not, as you can tell, it's not an exact perfect science. You know, it'd be wonderful, in the future, if we had ways of doing real-time measurement of what your immune system, you know, how revved up it is, and adjust your level of immune suppression in real time, like with a little computer and something's injected. I'm sure that sounds crazy today, but I'm sure 20 years from now, that's what we'll be doing. People will have little, like similar to an insulin pump, they'll have little needles, little pump, and it'll have kind of perfect immunosuppression for you. But we're not there yet. Hopefully you guys will all get there.
Very nice. Yeah, that was exactly what I was looking for. And thank you. It's, having a personality of wanting to be prepared. You know, you answered it perfectly. Thank you.
Good. Oh, you're welcome. All right, guys. Well, thank you for taking half of a Saturday to be with us. I hope the rest of the session was good, and I hope this one was as well. And I think that'll do it. You guys have a good day.
Thank you.
Thank you, Dr. Hundley. I'd like to remind all of the attendees that you guys will receive an email on Monday about the recording and the survey, and please take the survey so that we can help to plan our conferences for next year. I also like to remind you that our recordings are also going to be available on our YouTube page with other information. So once again, on behalf of GTF, we thank you so much for participating in this conference today, and have a good one.
Thank you.
Bye.